Hello! Today we finally complete the Brachial Plexus series with the nitty-gritty Brachial Plexus. So we're going to get into the cool stuff, which is gritty! No! Gritty! Stop!
Into my mind!
Bad gritty! So today we're going to expand our understanding of the brachial plexus. We really dive into what it's made of, how the neurons that it's composed of are distributed. We're going to define different types of injuries, and once we have that down, we're going to look at the upper and lower brachial plexus injuries to understand them, so we can finally learn to love the brachial plexus. So we know that the brachial plexus is a network of nerves that are braided together, that combine and divide, but we're going to make it a rainbow today. In previous videos, I taught you how to draw the brachial plexus, but I didn't talk about its components in the way we need to in order to understand injuries. We need to review the parts of the spinal cord meeting up with the peripheral nervous system, because if this isn't clear, the injuries will be difficult to understand fully. Looking at our spinal cord, which is a part of our central nervous system, we can see that the gray matter is sectioned into dorsal and ventral horns. Gray matter looks gray because of the nuclei in it, since gray matter is a collection of cell bodies in the central nervous system. Dorsal horns contain sensory cell bodies. Ventral horns contain motor cell bodies. The portion of our peripheral nervous system that connects to the central is the roots. We have dorsal and ventral roots that connect us to the spinal cord. These roots are made up of dorsal sensory axons and ventral motor axons. A special structure exists on the dorsal root and the dorsal root only, called the dorsal root ganglion. A ganglion is a collection of cell bodies in the peripheral nervous system. There is no ventral root ganglion due to the actual structure of motor neurons versus sensory neurons. Sensory neurons are considered pseudo-unipolar, and their cell bodies are not found at a pole or an end of an axon, but somewhere somewhat in the middle of it. When the ventral and dorsal roots come together in a sheath, they are considered a mixed spinal nerve due to the mixing of functionality. A spinal nerve contains both sensory and motor axons. Spinal nerves exist at every spinal level bilaterally, and each spinal nerve will branch dorsally and ventrally. The branches that head posteriorly are called dorsal rami, and the branches that head anteriorly are called ventral rami. Remember that the brachial plexus roots are really just ventral rami, which means each rami that makes up the brachial plexus has motor and sensory axons in it. Let me show you an example of a rami that we know. Rami are made up of both motor and sensory fibers, which means they perform motor and sensory functions. Motor is the innervation to a muscle that causes it to contract. Here's our example. Musculocutaneous nerve innervates the muscles of the anterior arm compartment. It makes them work. It makes the biceps flex. Sensory is the innervation from the skin that allows you to experience and interact with your external environment. Musculocutaneous nerve also innervates the skin of the lateral forearm. So if you get poked or pinpricked in that area of skin, you feel that via musculocutaneous nerve. It has dual function. Whereas spinal roots only contain one type of neurons. Dorsal is sensory, ventral is motor, rami are both. Never forget that the roots of the brachial plexus aren't the same thing as dorsal and ventral spinal roots. Brachial plexus roots are just ventral rami. So C5, C6, C7, C8, and T1 are our ventral rami, aka our roots of our brachial plexus. Today I want to explain and explore how these spinal nerves that are mixed spinal branches, also known as rami, are really just bundles of neurons that combine and divide with each other to create specific combinations of neurons that we call nerves and name. C5 has a nerve distribution that looks like this, as it contributes to multiple different structures. A nerve distribution shows you which nerves and parts of the brachial plexus are made up of neurons from each spinal level in this plexus. For example, C5 neurons divide in specific ways and only contribute to specific parts of this plexus. C6 has a different nerve distribution than C5, or C7, or C8, or T1. And sometimes C5 and C6 will combine together to create a nerve we name, but other times they're not together at all, or they're combined with other spinal neurons from other spinal levels. This is what we mean by distribution. And to add one more level of complexity, this is just one textbook's opinion of the average distribution that the average population has.
Say what?
I mean, you're going to see differences across different resources. As usual, memorize the distribution that your lecturer tells you is correct. The truth is, no one can 100% know the exact distribution in every individual, so we need to learn an average and then be okay with variation. How these neurons combine creates the nerves that we know. We know dorsal scapular nerve, but now we know it's made up of or composed of C5 neurons. We can see suprascapular nerve is different. It's composed of not just C5, but also C6 neurons. But why does that matter? Well, it matters a lot when we're trying to figure out and understand injuries to 1 or 2 spinal levels and how that would affect all the nerves that are made up of those spinal levels down the line. Or if they're only partially made up of those spinal levels down the line, what does that look like? When I say made up of or composed of, this is what I actually mean. When we zoom in on C5, C6, and C7, we can see the neurons that create those rami, and now we're going to see how they combine and divide. So C5 is supposed to make up dorsal scapular nerve. It's supposed to just be made of C5 and maybe some C4 neurons. We can see those combined together there. Whereas the superior trunk is made up of C5 and C6. So it's a bundle of C5 and C6 neurons. C7 just continues and becomes the middle trunk. So the middle trunk is really just the ventral rami of C7 continued. A nerve like long thoracic nerve is made up of different spinal levels neurons, C5, C6, and C7 combined to make the long thoracic nerve. And for the record, it's not just a singular neuron from each level. This is just a representation of each level contributing. So we can see branching off of our superior trunk, the suprascapular nerve made up of C5 and C6 neurons. And now I'm going to add in some of our divisions. There's our anterior division from our middle trunk and our posterior division from our upper trunk. So the posterior division from our superior trunk. Now the posterior division from our middle trunk and our inferior trunk, coming from C8 and T1, not pictured here, is going to make up a different cord. So our lateral cord is made up of C5, C6, and C7. Now we can see that in this image, whereas our posterior cord is made up of C5, C6, C7, C8, and T1. It's made up of every single level. So why does this matter? Because when we lose C5, we've affected multiple things and we haven't affected other things, and we need to know which things are affected and which things aren't affected. So once you've mastered drawing and labeling your brachial plexus, it's a good idea to start adding the levels that make up those nerves next to the name, maybe starting with our 5 major branches and building from there. My unsolicited advice to you is to never try to learn everything all at once. Once you master something, add a little bit more. That way you build instead of overwhelm. For some of you, lists are going to work better, and so use them. I actually will use this list later in this lecture to show you a trick to figuring out injuries. The next piece to this puzzle is understanding that the type of injury and the exact location of injury matter in terms of patient presentation. An avulsion is a term to describe a complete tear, meaning every single neuron that is physically torn at the spinal roots. That's the dorsal and the ventral roots. A rupture is a complete tear, I say, anywhere else in the peripheral nervous system. So this is complete tears of rami, mixed spinal nerves. Damage is different. Damage is an injury that doesn't 100% break all the neurons. Things like pinching, incomplete tears, neuromas, which is a benign nerve tumor, stretching, are going to cause issues, but in a very different way. Avulsions and ruptures cause complete losses of function. Like cutting an electrical cord to a lamp, the electricity no longer goes through the cord. The lamp does not turn on anymore. You can't make it function. Whereas damage to that electrical cord, it's frayed, it's cut, but only partially, may cause the light to falter or flicker, but it still sorta kinda works. That's the exact same thing going on here. An avulsion or a rupture will cause a complete loss of function, whereas damage will cause a partial loss of function. There are really specific things that happen to muscles and skin that those nerves innervate when complete loss versus partial loss occurs. So our motor symptoms when we completely avulse or rupture something are paralysis and atrophy, which is muscle wasting. Sensory systems are hypoesthesia, complete loss of sensation, no feeling at all, not even pins and needles. Partial loss of function is very different. It just is weakness of the muscles that are affected and paresthesia of the skin that is affected, which is essentially numbness, tingling, a burning sensation, those sort of things that happen when you sleep on your arm funny. Technically, you've damaged the nerve temporarily, and that's why you have that pins and needles sensation. So you can see there are major presentation differences between complete tears and damage. But the last piece to this puzzle is actually, where did the injury occur? Did it occur at the dorsal ventral roots or the roots of the brachial plexus? Did it occur in a cord, a trunk, or did it occur in one of those peripheral branches? Like, is median nerve severed or is just radial nerve damaged? Before we move back to the big plexus itself, I want to show you this with an example, and we're going to look at specifically the radial nerve. I've added in some general functions of the branches so you can see them in this image. So when we look at the nerve injuries in different places, you can think about the effect that might have based on the type and the location of that injury. So first example is an injury here, right after a radial nerve branches away from axillary, and the injury, in this case, is a rupture, so a complete tear, which means complete loss of function. So what does that actually mean for radial nerve? This means we cannot extend the forearm at the elbow, and we cannot extend the hand at the wrist, nor the digits. We have completely lost posterior arm and forearm muscle function. They are paralyzed. We also have lost sensory function of the radial nerve, so loss of the posterior arm, posterior forearm, and some of the dorsum of the hand have no feeling at all. When something like this occurs, a rupture specifically or an avulsion, I want us to start thinking about how the patient might present. Our muscles are always in a tonal battle, if you will, holding our joints in specific positions in a balance. There are different types of muscle contraction, and just because we aren't moving something doesn't mean the muscle is completely at rest. This is the idea behind muscle tone, that there is always some tension in a muscle or muscle group in order to balance out the equal and opposite muscle group that might do the equal and opposite action. And we're going to revisit this idea shortly, but I wanted to bring it up now. When I lose the ability to extend at the wrist and I haven't lost the ability to flex at the wrist, my wrist will exist in a flexed position until I fix my radial nerve problem, because the flexion action is unopposed by the extension action in this example. But what if the injury occurs more distally, farther down the nerve path, and this time, instead of a rupture, it's partially damaged? Maybe a Philly fanatic jumps out of nowhere and hits you with a baseball bat. Maybe you just fall down. Regardless of how it happens, the presentation of a partially damaged nerve is different than a ruptured one. Instead of total loss and atrophy, we will have weakness of the posterior forearm muscles. Not no feeling, but numbness and tingling, maybe burning sensations in our posterior forearm, skin, and dorsum of the hand. Due to the location of the injury, the branches that innervate the triceps are actually completely fine, and the triceps should function normally, but everything down the line from that injury will partially function. Our third example is a neuroma, a benign nerve tumor in the superficial radial nerve branch. A neuroma will damage or disturb the nerve's function, but won't eliminate it. The superficial radial nerve is solely composed of sensory axons, and therefore, since it is damaged, not ruptured, the patient will present with numbness and tingling or burning sensations, what we would consider abnormal sensations on the posterior forearm and dorsum of the hand. But there will be no muscle deficits because this branch of the radial nerve does not actually innervate any muscles. Muscle innervation is unaffected. One final scenario to consider is an injury to something more proximal, like the posterior cord, and this time we rupture the whole cord. All signals are lost down the line from the point of injury, and this time it's not just radial nerve that is affected, it's also axillary nerve. Depending on exactly where on the posterior cord, it could also involve upper and lower subscapular nerves as well as thoracodorsal nerve, but in this image it's just affecting radial and axillary. Hopefully, these examples help you understand how important location of injury and type of injury are to understanding patient presentation. In the next few slides, we're going to take this one step further so that when we get to exam questions, which are just a list of clues that are describing a patient presentation, we know how to work backwards to figure out what might be going on. So our next concept is tonic contraction. And I'm just going to be very honest with you. This is a theory, and there's some disagreement in the field on whether this occurs in all muscles or just some muscles. But regardless, I think it's actually going to help you understand patient presentation better when we discuss the main brachial plexus injuries in a few minutes. Tonic contraction is the idea that our muscles are never completely at rest. In order to hold our joints in what we might consider neutral position, a good example might be when your upper limbs are resting, quote unquote, at your sides. This idea is that both the flexion side and the extension side are in what's called tonic contraction. So in order to position the wrist neutrally, we are not extending at the wrist nor flexing at the wrist, but we are both flexing and extending to hold it in a neutral position. Almost like a battle between flexion and extension, but it's a tame one because there is no winner. In theory, if you stopped tonically contracting, you would in some ways end up as like a pile of bones on the floor. In our wrist example, we would be floppy, not holding it in a neutral position while we actively contract and move other parts of our upper limb around. Where this concept comes into play for us dealing with the brachial plexus injuries is that if you lose tone on one side because you have lost the nerve's function that innervates the muscles that do that action, then the other and opposite side will still have tonic contraction and therefore will pull your body at that joint into the opposite position, the one that still functions. This is considered overcompensation. The side that still has tone is overcompensating for the injury and pulling you into this other position. Another way to think about this is organizing muscles into agonist and antagonist relationships. Muscles that perform opposite actions are in balance with one another. Not to get too far into the weeds, but an agonist is the muscle or muscle group that is actively shortening and contracting. This type of contraction is called a concentric contraction. The agonist is the muscle or muscle group that is actively lengthening. This is called an eccentric contraction because instead of immediately releasing all the tension in the antagonist muscle group, in order to have control, we lengthen under tension. This allows for controlled movements and the agonist to concentrically contract and shorten while the antagonist eccentrically contract and lengthens. As I said before, it's a balance. Let me give you an example. During flexion of the forearm at the elbow, the anterior arm muscles listed below are agonists. They are actively contracting and pulling the forearm closer to the arm, which is flexion. But what we didn't probably consider is that the motion of the posterior arm muscles, the triceps, have to lengthen to allow us to shorten on the other side. They would be the antagonist group during flexion. During extension of the forearm at the elbow, the roles reverse, and the anterior arm muscles must relax and lengthen while the posterior arm muscles must contract and shorten to pull the forearm into an extended position. In this case, we switch. Anterior arm muscles are antagonists and posterior arm muscles are agonists. But if the nerve that provides innervation to one of these muscles groups is damaged or ruptured, we are no longer in balance, and therefore we are going to present in a position determined by the remaining functional groups. When you lose something completely, the opposite muscle group, if unaffected or less affected, will overcompensate. So here's a great example. I rupture my radial nerve, I lose extension of the arm at the forearm and extension of the forearm at the wrist and extension of the digits and some thumb abduction. This means I am stuck presenting in a flexed position at the elbow, wrist, and digits. Overcompensation occurs mainly during ruptures and avulsions because damage is variable. It will matter to what degree the nerve was damaged to determine how much overcompensation will occur.
And now,
we are ready to discuss upper and lower brachial plexus injuries. These are injuries at the roots, both dorsal and ventral spinal roots, which would be an avulsion, and brachial plexus quote-unquote roots, which are really ventral rami, which would be a rupture. And finally, sometimes the trunks, mainly the upper and lower trunk, because they are really made up of those aforementioned ventral rami. Injuries to either the upper roots or trunks or lower roots or trunks will cause very specific patient presentations. Let's start with upper brachial plexus injuries that affect C5 and C6 roots and superior trunk. Sometimes C7, but it's not typical. In these next images, what remains fully colorful is unaffected. What is grayed out is affected, and what has color and gray will be partially affected to different degrees depending on how much color there is and how much gray there is. In these avulsion rupture injuries, unaffected nerves will overfunction in terms of presentation, affected nerves will not function, and partially affected nerves will be weakened and partially function. Here is our lovely plexus pre-injury. We are adding in not the names of the nerves, but instead either what they innervate or the general function of the structures that they innervate. And now let's see what happens when we rupture C5 and C6 plexus roots. If we gray out all the contributions that these roots make to the nerves of our brachial plexus based on Moore's clinically oriented anatomy's distribution, we can see that some structures are completely grayed out and therefore lost, complete loss of function, while other structures are partially gray but not completely, and those partial grays are going to be weakened but not lost. Now remember, when we lose function completely, the opposite function, if unaffected, will overfunction and the patient will be stuck in that opposite position. For example, I lose a lot of abduction of the humerus at the shoulder in this injury. Supraspinatus and deltoid are paralyzed, and therefore the patient is typically stuck with an adducted humerus. And that's just one example. So let's learn more about this type of injury, and then we can break down the why of presentation. Upper brachial plexus injuries are often referred to as Erb-Duchenne palsy or Erb's palsy. Palsy just means weakness, and a man with the last name Erb was the first person to name and claim this patient presentation caused by the rupture or avulsion of the upper brachial plexus roots C5 and C6. Because each injury to the plexus is unique, there is absolutely some variation in presentation. We are examining an average presentation. In the real world, some levels might be ruptured and others might be stretched, and then it's a matter of degree of damage. But generally, these injuries present in the same way and are caused by similar traumas. Upper brachial plexus injuries occur when you overstretch the angle of your head and neck to the shoulder. When you increase that angle beyond what is natural with some force, it will typically cause this injury to occur. Common examples are falling from a motorcycle and landing on the side of your neck, or pulling on an infant's head during a difficult delivery and stretching the space between their shoulder and their head. This causes an Erb's palsy to occur, where the patient is usually stuck in a specific position called a waiter's tip. Due to the position of their upper limb, it looks like they are secretly asking for a tip, when in reality, they can't move their upper limb in any other way. On this slide, we can see a unilateral injury to an infant and see how their upper limb is positioned and how a bilateral injury would also present. Let's walk through why they look like this. So we have paralysis of the deltoid and teres minor due to the complete loss of axillary nerve, which is made up of C5 and C6. We also have complete loss of suprascapular nerve, also made up of C5 and C6. So our supra and infraspinatus muscles are paralyzed. We have very weak anterior arm muscles because our musculocutaneous nerve is partially functioning. It lost 2 out of 3 of its contributions. This means we have complete loss of abduction and lateral rotation, and a partial loss of forearm flexion and supination. So if we lost those actions, their equal and opposite actions will overcompensate, and our patient will be stuck presenting with an adducted arm, medially rotated arm, extended and pronated forearm, as well as flexed wrists and digits. But why the flexed wrists and digits? Let's get into the details. C5 and C6 contribute to radial nerve, which innervates our extensors of the wrist and digits, while only C6 contributes to median nerve, and the ulnar nerve is completely unaffected by this injury. Ulnar and median collectively innervate the flexors of our wrist and digits, and in this specific injury, more of the extensor side is affected than the flexor side. If you think of this as a battle between flexion and extension, extension is losing, and therefore flexion will win the presentation. I want us to visualize this in a couple different ways to prove to you why this makes sense. So I'm going to bring back up the list that shows us our levels and which nerves are made up of those levels, and I'm going to cross out C5 and C6 in this example, and we're going to ignore C4's contribution to dorsal scapular nerve for now because it doesn't really affect the presentation. So there they go. They're crossed out. So now we can see what we lost and by how much. So we have total loss of the dorsoscapular, upper scapular, nerves of subclavius, suprascapular, axillary, and lower subscapular nerves. We lost 2 out of 3 for long thoracic, lateral pectoral, and musculocutaneous nerve. We lost 1 level out of 3 for thoracodorsal. We lost 1 out of 4 for median, 2 out of 5 for radial, and none for medial pectoral, medial brachial, and antebrachial cutaneous, and the ulnar nerve. Because each nerve is made up of a different number of contributors, we really need to see this as a percentage of function, not just a number of loss. So I'm going to show it to you in 2 ways. First, we can examine what percentage of these nerves are not functioning. For example, the first 4 rows with total loss are 100% non-functional, whereas long thoracic, lateral pectoral, and musculocutaneous nerve are 67% non-functional, thoracodorsal is 33% non-functional, median is 25%, radial is 40%, and the rest are fully functional, therefore they are at 0% non-function. But non-functional for me was too much of a double negative, so I also arranged this by percent function. How much of the nerve is still functioning, which is the reverse of what we just did. So the first 4 rows are all functioning at 0%, no function. Long thoracic, lateral pectoral, and musculocutaneous nerve are functioning at 33%, a third of their normal function. Thoracodorsal is functioning at 67%, 2/3 normal function. Median at 75%, radial at 60%, and medial pectoral, the medial antebrachial and brachial cutaneous nerves, as well as the ulnar nerve, is functioning at 100% function, fully functional. Why did I do this? Because now I have proof of which nerves are functioning more than other nerves, and therefore I know which nerves will win in a tonal battle based on the percent function. So in order to use this information, I made a visual representation of some of these agonist-antagonist relationships and the nerves that provide those muscle groups with innervation. So I made a literal battlefield. Here we can visualize Erb's palsy in battle form. The 5 red R's represent radial nerve and all of its contributions, the 5 levels that contribute to it. Aqua MC soldiers represent musculocutaneous nerve and its 3 levels of contribution. Median nerve is yellow, MED, and U soldiers are ulnar nerve in purple. You may also notice that median and ulnar soldiers range in size. Median soldiers are large in the forearm muscle section and smaller in the hand, and ulnar is the reverse of that due to how many muscles they innervate in each area. Median nerve innervates most of the anterior forearm muscles, but ulnar nerve innervates 1.5, whereas in the hand, most of the intrinsic hand muscles are innervated by ulnar nerve and only 5 are innervated by median nerve. So I use size to represent that relationship. Then we have it split up by the area that these nerves innervate by function to see what happens when the injury occurs. So let's see this injury happen. So C5 and C6 are damaged. Let's see what happened. In the arm, we have triceps versus biceps and friends, forearm extensors versus forearm flexors. It's not about exact number of soldiers lost, it's about percentage lost. And percentage-wise, because radial nerve's army is made up of more levels, radial nerve is functioning at 60%, and musculocutaneous nerve is functioning at 33%. Therefore, there's a clear winner, that is the forearm will be in an extended position because the radial nerve has more function than the musculocutaneous nerve. They win this battle for patient presentation. Innervation of the posterior forearm muscles is radial nerve again, so extensor side is still radial, but this time radial is in competition with median and ulnar nerve, who share control over the anterior forearm muscles. Now, like I said before, it's mainly median nerve innervating these anterior muscles, but ulnar does contribute. Radial nerve's 60% function may have won the arm compartment forearm position battle, but the wrist and digits fight is dominated by median and ulnar nerve. Median is functioning at 75% and ulnar is at 100, which collectively bullies the wrist and digits into a more flexed position. One battle I didn't include on the slide but should and could be considered here is the supination-pronation battle between musculocutaneous and radial forming an alliance in the name of supination and median nerve stepping up for pronation. Radial and musculocutaneous nerve are damaged, musculocutaneous nerve quite significantly, and therefore we end up in a pronated position as median nerve comes out the winner. Finally, I included the hand, but it isn't a battle at this point. As we know, we are in a flexed position at all of the joints of the digits. The only thing of note is that grip strength might theoretically be fine, because ulnar nerve is functioning great. But there might be slight weakness in the thumb, which is pretty much irrelevant when you are stuck in a waiter's tip position. While I didn't put it in battle form, you can basically do this for every part of this presentation. You lost your lateral rotators of the humerus at the shoulder completely, and while some of the medial rotators are functioning less than normal, they are in fact functioning at some percentage, and therefore you're going to be stuck in a medially rotated arm position. You lost supraspinatus and deltoid function completely, which means you've lost abduction from 0 to 90 degrees. We don't typically walk around with our upper limbs above 90 degrees, so don't come at me with that. You could still abduct with the trapezius muscle from 90 to 180 because it's literally irrelevant. So to summarize, Erb's palsy presents with an adducted, medially rotated arm, an extended and pronated forearm with a flexed wrist and digits. The buzzword will be waiter's tip.
Give me more money.
Now that we understand the upper brachial plexus injury, the lower is a lot quicker to learn and just generally occurs less. This is an injury to the C8 and T1 spinal roots, brachial plexus roots, or inferior trunk. If C7 is going to be damaged, it's more likely to happen with this injury than the upper injury. So we're going to include C7 in some of these examples. But not this one. Here's version 1, an injury to C8 and T1 brachial plexus roots. So we cut those roots and we gray out everything they contribute to. We have weakness in median, radial, and thoracodorsal, the degree to which we'll look at momentarily, and we have complete loss of ulnar nerve and our medial cord branches, the cutaneous nerves and the medial pectoral. This is the more common presentation without C7, but I want you to see and appreciate the differences. So this is the version where we're going to include C7 when we cut everything. The degree of injury increases significantly when C7 is involved, but you get generally the same presentation, weirdly enough. It's mostly the same structures affected, but the degree to which they are affected has increased, with of course the exception of the lateral pectoral, long thoracic, and musculocutaneous nerves that were not affected before. Both of these lower brachial plexus injuries will cause a palsy called Klumpke's palsy. Remember, that is essentially the name of the patient presentation. Klumpke's palsy for lower brachial plexus, Erb's palsy for upper brachial plexus injuries. Up in the burbs, down in the clumps is one way to remember that. This injury is atypical because we don't often overstretch the angle between the upper limb and the torso, essentially the armpit. If we still swung from vines, maybe this would be more common, but because we don't often fall out of trees or off of mountains and grab onto branches and shrubs for dear life, and thankfully it's uncommon for an infant to be pulled out of a womb by their arm, this palsy is very uncommon. But we're going to learn it anyway. And it presents with this Klumpke's claw hand. You're all crunched up or clumped up. It looks a bit like this little baby. But why does it look like this? We always want to understand why, because then we can reason against our anxiety on test day that makes us second guess and doubt what we know. If we understand these concepts instead of just memorize them, we can prove with confidence what we know and win the internal fight. This injury mainly affects ulnar, radial, and median nerves, which is going to be reflected in our patient presentation. These patients typically present with a flexed forearm due to the radial nerve being weakened, but musculocutaneous is unaffected, and over-functioning flexion of the forearm will put it in a flexed position. A supinated forearm. So let's do the math. There are two pronators of the forearm. Both are innervated by a weakened median nerve. There are two supinators. One is innervated by a weakened radial nerve, but the other is the biceps brachii, and musculocutaneous nerve is fully functional. Therefore, we have three weak muscles. Two pronators, one supinator, but we also have one strong one that is a supinator, so we're going to be stuck in supination. We will see to what degree the radial and medial nerves are injured shortly, but we will find Klumpke's patients with a slightly extended wrist due to the radial nerve being less affected, and quasi-extended and flexed digits. We will get really specific joint-wise for this palsy in the hand. This is Klumpke's claw broken down by joint. At the metacarpophalangeal joint, MCP for short, we are more extended. At the proximal and distal interphalangeal joints, PIP and DIP, known as pips and dips, we are more flexed. And the degree to which they are flexed is dependent on the specific digits. So we're going to get into the very specific why these things are happening in the next slides. Okay, let's look at our list. And in this version, I'm going to use orange to show the C7, C8, T1 injury and red to show the C8 and T1 injury. So you can see red crossed out just C8 and T1, but orange will represent our C7s being crossed out. And then we're going to have two values for each of those different types of injury. So we can see how much we lost when C7 is involved and how much we lost when it's just C8 and T1. I'm going to skip the not functioning version and just show you the percentage of function that each one of these nerves has. So we can discuss that here. So we have 100% function of the nerves in all four top rows of our list and all top 5 rows when it's our typical C8 and T1 injury without C7. When C7 is involved, long thoracic, lateral pectoral, and musculocutaneous function at 67%, thoracodorsal at 33%, median at the low 25%, and radial at 40%. When it's just C8 and T1 involved, long thoracic, lateral pectoral, and musculocutaneous are fully functional. Thoracodorsal is at 67%, median jumps to 50%, and radial is at 60%. In both injuries, we completely lose medial pectoral and the medial brachial and antebrachial cutaneous and ulnar nerves. What I really want you to focus on and take note of is how close the theoretical battle between median and radial nerve might be. Median is at 50% function, radial is only 10% higher than that. But ulnar is lost completely, so it's going to be a pretty interesting battle. So let's take a look at it. Same setup as last time, but different fallout. In terms of arm compartment muscles and how our forearm will end up positioned, we sustained no losses on the musculocutaneous side. Remember, this is a percentage, not soldier-to-soldier number. Musculocutaneous is at full function in C8 and T1 injury. Radial nerve is at 60% function. Even in a C7 injury not pictured here, musculocutaneous still wins, since the battle is musculocutaneous at 67% and radial at 40%. So regardless of how many levels are injured in this lower brachial plexus injury, musculocutaneous wins and we are stuck in a flexed forearm position. This battle is much closer to call at the wrist and digits. Let's use the C8 and T1 injury as our example here. Radial nerve functioning at 60%, median is functioning at 50%, and ulnar nerve is at 0% function. So at the wrist, we should be slightly more extended depending on the degree of injury. At the different joints of the digits, it's a little more complicated and variable, but let's walk through it. Typically in this presentation, the MCP joint, the metacarpophalangeal joint, your knuckles are in an extended position. This makes sense because radial is winning, right? But at the proximal and distal interphalangeal joints, we end up in a flexed position, and we're flexed at different degrees. Now, we can probably both agree that 60 and 50% are not that different function-wise, so we need to consider more factors. We need to consider the number of muscles that do these actions, and by these actions, I mean extension and flexion of the digits at the DIP and PIP joints. We only have one extensor digitorum. That extends at all the MCP, PIP, and DIP joints. This is because of a structure on the dorsal aspect of the digits called the expansion hood that the extensor digitorum blends into and spans all of these joints. Whereas on the flexor side, we have two flexor digitorums, one for the PIP, the superficialis, and one for the DIP, the profundus. In a way, two muscles are stronger than one and would arguably put more tension on those joints to be pulled into a flexed position versus the one on the other side. So the PIP and DIP joints are usually in a quasi-flexed position. But one more important addition to this puzzle is that ulnar nerve is non-functional and innervating half of the digitorum profundus on the flexor surface. The fifth and the fourth digit portion are innervated by ulnar nerve. So in a Klumpke's claw presentation, the second and third digit, innervated by median nerve, are more flexed than the fourth and fifth digits. Lastly, in the hand, we would lose grip strength significantly. Our hand is also stuck in a claw, so I don't imagine someone trying to pick up anything, but I like to be thorough, and because ulnar nerve is so damaged, we would have a lot of trouble gripping things with our hands. So who won? Well, TBD, and really DOP. It's dependent on the person and the exact degree of injury. So we will say it's variable, but we will learn the average for our tests. You may have noticed that the shoulder wasn't mentioned this time, and that's due to the fact that the innervators of that area are for the most part fully functional, so there's no real battle for position going on at that joint. So our Klumpke's palsy presentation really only affects the forearm, hand, and digit position. We have a flexed and supinated forearm with a slightly extended wrist, slightly extended MCP joint, mainly flexed second and third digits with a less flexed fourth and fifth. Remember, the superficialis for the fourth and fifth still functions, but it's a 50 to 60% battle against radial nerve there. So radial nerve's gonna fight a little harder. The main takeaway from this portion, I hope, is that this presentation is going to be variable, and that variability is due to the uniqueness of each injury and each individual. For those of you who like summary slides, here yours is. Do what you gotta do, take a screenshot, whatever. As always, thanks for watching. Like, share, and subscribe, and tell your friends or your enemies. I don't care. We just need people to watch these videos. All right, toodles!
Yahoo!